So, as a reminder, this was the pivotal study that led to the approval of CPX-351. So this was a randomized study for patients with secondary acute myeloid leukemia that could have been secondary to prior chemotherapy for other malignancies or secondary from an MDS or other hematologic disorders. And they were randomized to receive CPX-351 or 7+3, which was the standard. And as a reminder, CPX-351 is this liposomally encapsulated combination of cytarabine and daunorubicin that maintains that 5:1 molar ratio. The primary endpoints of the study were met. There was a significantly improvement in overall survival, as well as in response rates and other measures of efficacy, which were secondary endpoints. And then that was at the 12-month mark. And then with the continued follow-up, with 5 years of follow-up, we have continued seeing that benefit. Those curves have actually maintained that separation in favor of the CPX-351. So this drug is now approved precisely for those patients that are diagnosed with acute myeloid leukemia, secondary acute myeloid leukemia, again, either from another malignancy and chemotherapy for that, or from an MDS or with MDS-related features in their bone marrow. The interest in doing this particular analysis, now that we have the mature data for 5 years, was that although every patient was classified as an acute myeloid leukemia, we know that the percentage of blasts sometimes has been suggested to have prognostic implications, so higher blast count having a worse prognosis. And then there are categories, particularly those with less than 20%, that the WHO and other classifications accept as a diagnosis of acute myeloid leukemia, even though they have less than 20% blasts in the bone marrow, but they have either more than 20% in the peripheral blood, or they may have particular molecular cytogenetic abnormalities that make the diagnosis of AML even with a lower blast percentage. So the question is, what do these different categories or subsets of patients with different blast percentages, do they have different outcomes? And particularly, does the benefit of CPX-351 apply to all of them, or is it mostly driven by those with a higher blast percentage or with a lower blast percentage, or any one of these groups? So we wanted to investigate that, and that was the genesis of these analyses. Well, the first thing we did is to look and confirm that the arms are balanced within each of these subsets, and the way we classified the patients, we divided the total population was less than 20% blast, 20 to 40%, more than 40 to 60%, and then more than 60%. So, of course, each one of these subsets have lower patient numbers, but within those cohorts, they are all balanced fairly well in terms of their age distribution and performance status distribution and so on. And being that the overall survival was the primary endpoint for this study, that was the main focus of these analyses, is the overall survival benefit applicable to all these subsets. And indeed it is. We did see that the median overall survival was better for each one of these 4 categories according to the blast percentage. And we also looked at the event-free survival, and the same applies. It is better with CPX-351 across each one of these categories of blast percentage. So it supports the benefit of CPX-351. Then we also did an analysis for patients who received a stem cell transplant, because a significant subset of patients received CPX. We had seen in the overall population that even among the patients who get a transplant, the survival benefit is noticeable for the patients that receive CPX, and the same can be said in these analyses per blast percentage. And then finally, we looked also at the response rate. Again, that was a secondary endpoint, but important to notice. And we saw that the response rate was, again, better for the patients that received CPX in each one of these blast percentage cohorts that we analyze here. So in summary, from the efficacy point of view, the benefit translated across the different subsets of patients, whether they had less than 20% blast, all the way to more than 60% blasts. Well, I think that what this says is that it solidifies the indication of CPX-351 as the standard of care for these patients with secondary acute myeloid leukemia. With this analysis, we know that benefit extends across the spectrum of patients by their blast percentage in terms of the efficacy. And by the way, we also looked at the safety, and similarly, the safety profile is very similar across the subset. So again, that gives us confidence that no matter what the patient characteristics or the disease characteristics may be for our patients, CPX would be likely to provide a benefit over the standard 3+7 that we use for patients that do not have a secondary AML, and that was the standard for these patients as well up until this study. Well, I think that one of the areas where we're very interested is, can we extend the use of CPX to other disease categories with these benefit and with the long-term showing these continued benefit and if anything, improved benefit, increasing benefit. Could we extend these benefits to patients that have de novo AML, for example? And studies are ongoing looking at these subsets of patients, and hopefully we can see an equivalent benefit as we saw for these patients with secondary acute myeloid leukemia. We're excited about this new drug, and we continue improving our therapies for AML, and hopefully, little by little, we'll completely eradicate this disease and be able to cure the large majority of patients.